Hi, my name is Jason E. Lake. I'm an orthopedic surgeon specializing in foot and ankle, and I'm going to take a few minutes to discuss neuropathy of the lower extremity. What is neuropathy? Neuropathy basically is damage to nerves, typically outside of the spinal cord and brain, and there are different types of neuropathy. Motor neuropathy involves damage to the nerves that affect our muscles and movement. Sensory neuropathy affects sense of touch, and autonomic neuropathy is damage to nerves that are really out of our conscious control, things like sweating and function of our vital organs. So how does neuropathy occur? Well, it can occur several ways. Neuropathy can be caused from compression or from trauma, and it can also be caused from distal to proximal. So compression and trauma will typically involve injuring a nerve somewhere in the body, and then things distal to it don't work correctly, as opposed to peripheral neuropathy, which starts distal in the tips of the toes or fingers and then works its way more proximally. And peripheral neuropathy is typically more systemic, so things like toxicity, nutrition deficiencies, degenerative or hereditary, or secondary to medical conditions such as diabetes, kidney disease, or vascular disease. And all of these are very common in our hospitalized patients. So who gets neuropathy? Well, depends. Compressive neuropathy is often mononeuropathy, and essentially that means that a single nerve is compressed. It's rare to have compression of multiple nerves, but it is possible. Compressive neuropathy can happen at nerve roots coming out of the spine, such as a herniated disc or from arthritis or change in the spinal column. Additionally, patients can have peripheral nerve compression in the lower extremity at the level of the knee or even down in the ankle. For example, tarsal tunnel is very similar to carpal tunnel in the wrist, but a nerve can get compressed and cause neuropathy in the foot from an isolated site of compression. Traumatic neuropathy are also usually in single nerve, and the nerve can actually be cut, or it can just be contused, and this can be from a direct blow or some source of pressure externally, which can damage the nerve. Other people that get peripheral neuropathy, the other type of people that can get peripheral neuropathy are people who get it in relation to age, whether the nerves somehow degenerate over time or have a hereditary neurologic condition. And probably the most common discussed hereditary neuropathy is Charcot-Marie-Tooth, and in this case, the peripheral nerves get damaged and diseased, and over time, the neuropathy sets in, and it affects certain muscles more than others. And so patients start to get a classic high arch where their ankles start to roll. But there are other types of hereditary sensory and autonomic neuropathies as well, which is a little bit more in depth and outside of the goal of this discussion. The last classification of people who get peripheral neuropathy are people with medical problems, and the big one here is diabetes, but also peripheral vascular disease or kidney disease can cause this as well, and often patients with diabetes have peripheral vascular disease or kidney disease as well. For diabetes, essentially the high blood sugar over time starts to do two things. The first thing it does is it damages the nerve itself, and the second thing that it does is damage the small blood vessels, and these small blood vessels feed the nerves, and so if the nerve becomes dysvascular, then it starts to add to the disease that's there already from the high blood sugar over time. So the theory is that the diabetes causes the neuropathy from multiple different aspects. What are the symptoms of neuropathy? Well, several. Patients can have burning, tingling. They can have numbness in their feet. Sometimes the burning will be described as pain, and sometimes it's more burning. Additionally, the patients can present with subtle weaknesses. So in the lower extremity, they can lose the ability to pull their foot up, turn their foot out, spread their toes. And that last one can be a more subtle weakness that presents in some patients. Additionally, as time goes on, you start to see temperature changes, changes in the skin, and hair growth in people who have peripheral neuropathy. And some of these things can also happen in people with peripheral vascular disease as well. And so patients can have one or the other or both. How is peripheral neuropathy diagnosed? Well, several ways. First, history is very important. You want to ask the patient if they have any sensory problems, weakness, or autonomic changes that they've noticed. That's a start. On physical exam, there will be decreased sensation to light touch, pinprick, monofilament testing, even decreased two-point sensation testing or vibration testing. Sometimes there will be temperature changes, hair growth changes, contractures of the toes, foot, or ankle, and then evidence of abnormal weight bearing, such as calluses or ulcers can be present. Whereas in a normal person, they start to have pain, they change the way they walk, but in someone with neuropathy, they may not know a callus or an ulcer is developing, and so they keep pushing through it. They don't have the pain to protect them, and so as they keep pushing and pushing, the skin starts to break down and then an ulcer forms. Other ways peripheral neuropathy can be diagnosed are through blood work. So if someone has a vitamin D deficiency or a toxicity, blood work can be ordered to check this. Additionally, there are some genetic tests for hereditary neuropathies. An EMG or a nerve conduction study is sometimes ordered where patients can actually have their nerves tested to look for whether or not the nerves are compressed or if it's coming from proximal to distal, such as a peripheral neuropathy. This can be helpful, typically done as an outpatient, not as an inpatient test. Additionally, MRI as an outpatient can be helpful to pick up neuropathy. Sometimes you'll see fatty change in the muscle because it's not getting the signal, so the muscle doesn't look as bulky or as strong. And then you can also look for compressive lesions or just changes in large nerves on the MRI will sometimes be indicative of neuropathy. Again, this is typically on the outpatient basis where you would order an MRI as opposed to on the inpatient basis. Additionally, for peripheral neuropathy, occasionally a biopsy can be performed. It's pretty uncommon. It would really be kind of a last resort if other tests are not coming back positives and things aren't adding up. This will typically be done as an outpatient and would not be ordered on a patient who's in the hospital. So how is peripheral neuropathy treated? Well, essentially you try to treat the condition causing the neuropathy first. So if it's a compression lesion, then you want to try to eliminate the compression if possible, whether it's external or internal. You want to treat the diabetes, the vascular, the kidney disease, try to get those optimized to prevent the neuropathy from getting worse. And if there's any vitamin deficiencies such as B12, you want to correct that or address any other toxicities. There are medications that have been tried, medications like gabapentin and Lyrica. Sometimes will help with burning pain, but don't necessarily eliminate the neuropathy. CBD and some other supplements have just started to become to be studied, but there isn't any official recommendations regarding this. And similar recommendations for Tenjune. It helps some people, but we're not sure if it helps everyone. Additionally, orthotics and bracing can be used. Sometimes if the patient has a deformity, we have to accommodate for the deformity or support it. For example, on an inpatient with neuropathy whose been in bed for a long time and not moving, they'll sometimes get a pressure sore on the heel, and a device can be designed to pad the rest of the foot and essentially take the pressure off the heel posteriorly, like this device, to allow the skin to heal and again helps the patient with neuropathy. Additionally, surgery sometimes performed. This is typically for people with deformities who need correction, significant weakness, or if there's a compression lesion, sometimes this will be addressed surgically. The other big key for treatment is really patient education. Once neuropathy is there, especially peripheral neuropathy, there's not a lot that can be done to make it go away. So we have to educate the patients what neuropathy is, what to watch out for, and then having really close follow-up. One example would be is if you have neuropathy, you should never go barefoot. Essentially, you could step on a piece of glass or step on a hot surface, damage the skin, get an infection, but really not know it because the protective sensation is not there. Thank you for letting me take a few minutes to cover peripheral neuropathy. Please do not hesitate to contact me with any questions. Thank you.